Okay, so today we will continue our discussion from abdomen. In our previous lecture, we covered up to page number 40. So today we will continue from there. Can you see the screen? Can see the screen now? Should be. Something went wrong. Screen. Now can see the screen. You can see in my camera, but screen sharing. Are you able to see the screen? This shared screen. Okay. Hi, Dr. Zania. We will start. No, it's okay. It's very normal. Uh-huh. No problem. It happens. This is part of our life. Okay. Are you able to see the shared screen, or you are observing it from my camera? I mean, okay, then let's continue. Nothing. Just we were. She was asking about the exam date and this thing. So I said, both of you, you can focus for January. And that will be better. Mm-hmm. Okay, so let's begin. Already we have seen these parts. We were in page number, I think, 40. Foregut, midgut, and hindgut. Okay. Anyone from you, could you please repeat blood supply of rectum? Blood. Always make it a habit. Whenever you will say any blood vessel, try to say their origin. Branch of. Superior rectal artery, branch of. Mhm. Very, very good. Very good. Okay. And peritoneal relation of rectum. Either way, just you need to explain. No, no, no. You need to tell me the peritoneal relation. Make it very simple, very simple. Whole posterior aspect of the rectum is retroperitoneal. There is no peritoneum. Then whole lower third of the rectum is retroperitoneal. Middle third of the rectum only. So peritoneum is something like this. You can see this picture. Something like this. Only this part. Lower everything is extraperitoneal. The lower part there is no peritoneum. Anterior, lateral, posterior there is no peritoneum. Middle only anteriorly there is peritoneum. Lateral and posterior no peritoneum. And the upper anterior and lateral have the peritoneum but not posterior. Foregut, midgut and hindgut. Foregut develops from, okay, foregut gets supply from which blood vessel? Celiac trunk. And origin, vertebral level, T12. What are the branches of the celiac trunk? Left hand side. Left gastric, common hepatic and spleen. Okay. Then midgut gets supply from SMA and vertebral level L1 and hindgut inferior mesenteric vertebral level L3. Both of you, no, no, no. Venous drainage, very important. Venous drainage from regional veins that accompany arteries to superior and inferior mesenteric vein. The inferior mesenteric vein drain into splenic vein. Please remember this very, very, very carefully. Inferior mesenteric vein drain into splenic vein. Again, inferior mesenteric vein going up and it draining into splenic vein. This is spleen. So this is inferior mesenteric vein and this is splenic vein. Inferior mesenteric vein draining into splenic vein. Then medial colonic vein drain into superior mesenteric vein. Medial colonic vein drain into superior mesenteric vein. Here we have medial colonic vein. It is draining into superior mesenteric vein. Okay. Then splenic vein join superior mesenteric vein behind neck of the pancreas. Again, splenic vein. Suppose this is splenic vein. Inferior mesenteric vein draining into splenic vein. Still, its name is splenic vein. No change. And when splenic vein again joining with SMA, superior SMV, superior mesenteric vein, then their name changing. Superior mesenteric vein when joining with splenic vein, then its name becoming PV, portal vein. And portal vein entering into the liver. Okay, who can repeat quickly? Mhm. Very good, very good. Superior mesenteric. Yes. See the picture. This is inferior mesenteric vein, right? Inferior mesenteric vein draining into, and this is splenic vein. Inferior mesenteric vein joining with the splenic vein. Even after joining this part, before entering to the superior mesenteric vein, still this part name is splenic vein. And from the inferior part, this is superior mesenteric vein. When splenic vein joining with the superior mesenteric vein, now its name becoming portal vein, and portal vein entering into the liver. Now, this is very important for MRCS part A, part B, C, D, E, F, G, everything. We should not forget blood supply of stomach. Very easy if you remember the previous. This is diaphragm, right? So diaphragm, how many opening we have in diaphragm? 12 opening is for descending thoracic aorta. Descending thoracic aorta, at which level fires as the diaphragm? T12. What are the branches at T12 level abdominal aorta have? And very good, very good. Inferior phrenic artery. Inferior phrenic artery, inferior phrenic artery, right and left, both sides. Inferior phrenic artery. At the same level, we have celiac trunk. So we just studied that foregut getting supply from celiac trunk, CT, midgut getting supply from superior mesenteric artery, and hindgut getting supply from inferior mesenteric artery. Okay, so foregut starts from which part? Foregut starts from esophagus, then stomach, right? Up to, up to, up to, up to second part of the duodenum, mesoduodenal papilla, right? This is foregut. It starts from the esophagus, foregut extension. It starts from the esophagus and up to second part of the duodenum before the opening of the mesoduodenal papilla. So be very confident. If anyone or in any question, if you get any blood supply, that this part, first part of the duodenum gets supply from which blood vessel? If you forget everything, only if you can say branch from the celiac trunk, that is also correct. Because you know this is the part of foregut, and foregut is solely supplied by the celiac trunk. Okay. Then midgut supplied by midgut extension from second part of the duodenum up to proximal two-third of the transverse colon. And hindgut extension, both of you looks very pale. You are not getting my point. Okay. Hindgut extension from where to where? To anus. Okay, good. Okay. So now celiac trunk. Celiac trunk, we say celiac trunk has branches. What are the branches? Celiac trunk, left and side. Mhm. Left gastric artery. Left gastric artery. First see celiac trunk coming and giving branch left gastric artery, and left gastric artery giving supply throughout the lesser curvature. We know the parts of the stomach, right? This is lesser curvature, then this is greater curvature. This is pylorus, and this is card fundus of the stoma, and here this part we can say cardiac notch. Okay, so left gastric artery mainly gives supply through the laser curvature. First, they arises, goes up, then they give a descending branch. Okay, descending branch actually directly attached with the stoma. See here, left gastric artery goes up and it divides. One branch goes up, one branch comes down. So the branch goes up. It is called esophageal branch. Esophageal branch. It gives supply lower part of the esophagus as well. And this esophageal branch comes from the left gastric artery. Okay. So from left gastric artery mainly giving supply in the laser curvature. Now hepatic artery. This is splenic artery. Splenic artery giving supply in the bed of the stomach. Not very important here, but after reaching to the spleen, it splits into two parts. One part goes up to give supply in the fundus. This is called short gastric artery. So short gastric, yes, and one branch comes through the greater curvature. This is on the left side, right? So this will name as left gastro-omental or left gastroepiploic artery. Again, splenic artery dividing into two parts, one part coming through the greater curvature, descending, and one part going up, ascending, short gastric artery, giving supply to the fundus. Fundus of the stomach getting supply by short gastric artery, and greater omentum, greater curvature is getting supply from the left gastroepiploic artery. Okay, so we finished splenic. Now remaining common hepatic. Why common hepatic? Because initially when it arises from the splenic trunk, it is not divided to either right or left. That's why it is common. Common hepatic artery giving branch right gastric artery. Before we got one left gastric artery. This is left gastric artery, direct branch of the celiac trunk, and right gastric artery is the branch of common hepatic artery. Okay, and this right gastric artery also trying to give supply in the laser curvature. Laser curvature, we have seen left gastric artery giving supply. Yes. So right and left both gastric artery giving supply mainly in the laser curvature, and they are making an anastomosis. See, this left gastric artery going up, one branch going up, one branch coming down, and waiting to meet with this right gastric artery. Okay. So first branch we are getting right gastric artery, then we are getting another branch which is giving supply to the duodenum. Also the pylorus of the stomach. That's why its name is gastroduodenal artery. Gastroduodenal artery, also branch of common hepatic artery. So gastroduodenal artery again coming here and dividing into two parts. One part giving supply through the greater curvature to meet with left gastroepiploic artery. Left gastroepiploic artery coming up to almost half of the greater curvature, and the remaining half is giving supply by right gastroepiploic artery, which is a branch of gastroduodenal artery. Okay, so one branch of the gastroduodenal artery giving supply to the greater curvature of the stomach, another branch going inferiorly to give supply to the pancreas as well. That's why its name is superior pancreaticoduodenal artery. Superior pancreaticoduodenal artery. Okay. So again, gastroduodenal artery coming from the common hepatic artery or hepatic artery proper. and giving two branch, one branch going through the greater curvature named as right gastrocupilic artery, another branch giving supply. Here will be the spleen. This is duodenum. In the curvature of the duodenum, there will be what? Pancreas. Pancreas. Tail of the pancreas is attached with the spleen, right? So this branch giving supply to the duodenum and pancreas as well. That's why, and in the superior part. So its name is superior pancreatico-duodenal artery. So there is a common rule. If there is any superior, there must be inferior. So there is inferior pancreatico-duodenal artery also, right? So inferior pancreatico-duodenal artery will be a branch of superior mesenteric artery, SMA. If I'm not wrong, I studied when I was very young. Yeah, maybe before discussing, we need to be confident. Otherwise, this is being recorded, and if after 50 years someone listens to this, then there is a wrong teacher or someone was discussing wrong. Okay, anyway. So we got gastroduodenal artery giving two branch. One is right gastrocupilic artery, another branch is superior pancreatico-duodenal artery. Now the terminal part of the common hepatic artery, which is going one branch going right side to the liver, another branch left side of the liver. So simple their name, right hepatic artery in the right lobe of the liver. This is liver, and another branch going to the left lobe, left hepatic artery. Again. Very simple. Stomach gets supply from the celiac trunk, which has three branches: left left hepatic artery, splenic artery, and common hepatic artery. Left gastric artery. Left common hepatic. Mhm, mhm. So the greater. Okay, Dr. Sanjida, you can just tell the branches of celiac trunk. Okay, what are the branches of common hepatic artery? Mm-hmm. No. Yes. Yes. Superior pancreaticoduodenal artery coming from gastroduodenal artery. Mhm. Yeah. So here you can see left gastric artery. Mm. Mhm. Mhm. It is not becoming right gastric artery. Your confusion is very logical. there is another nail. Okay, mainly see if we zoom in the picture mode, this is left gastric artery going up. Another branch giving supply to the laser curvature. Okay, you can say it branch of the left gastric artery. Okay, branch of the left gastric artery directly giving supply to the laser curvature like this. Okay, and it is not covering the whole laser curvature because right gastric artery also going up to meet with here. Right gastric artery covering up to here, and left blood supply from branch of the left gastric artery, and remaining is supplied by the right gastric artery, which is a branch of common hepatic artery. Okay, yeah. Now we can see here left gastric artery, common hepatic artery. We have the branches: right gastric, gastroduodenal, hepatic proper. Okay, and splenic. Okay, from celiac trunk while traveling up to the spleen. Here is the pancreas, right? So this splenic artery gives multiple branches to the pancreas, small branches. So these are also the branches of the splenic artery. That's why splenic artery, if we say the branches of the splenic artery, we need to mention pancreatic branches. Then we have short gastric and we have left gastrocnemius. Now gastroduodenal artery, very important. Gastroduodenal artery arises from where? Common hepatic artery. Yes. And it passes behind the first part of the duodenum. And they give branch right gastrocnemius artery and superior pancreatic duodenal artery. We are clear up to here. Now, if there is any peptic ulcer, okay, or duodenal ulcer, mainly bleeding occurs from the posterior aspect. Okay, so if there is uh, any bleeding in peptic ulcer, mainly it occurs due to rupture of the gastroduodenal artery. Okay, its erosion is the main cause of bleeding duodenal ulcer. Yeah, bleeding can happen from stomach as well, right? Bleeding can happen from stomach. Also, it can happen from the duodenal because peptic ulcer in broad term we say peptic ulcer, but if we make it branch, there would be gastric ulcer and duodenal ulcer. So gastric ulcer bleeding can happen from any erosion, but if it is duodenal ulcer and bleeding, mainly this bleeding occurs from gastroduodenal artery, and this is very forceful bleeding, and especially if any patient present with any bleeding peptic ulcer, first we suspect it could be a gastroduodenal artery erosion. That's why immediately we need to take the patient for endoscopic ligation, right? Endoscopically, we try to reach up to here, and we try to put some clip to occlude the bleeding. Okay. Now hepatomegaly, no need just clinically. No need. 6 to 12 centimeter in right mid clavicular line. Okay. Okay. You know how to examine, how to palpate how to do ears flexion, palpation, auscultation of abdomen. Of the liver supplied by the right hepatic artery. Remember, common hepatic artery arising from the celiac trunk. This is supposedly celiac trunk, and this is common hepatic. Common hepatic first giving which branch? Uh, No, no, no. First branch. First branch. This is common hepatic. Relax, breathe, and answer. Common hepatic artery giving first branch. What is the first branch? Oh, mm-hmm. Then what is the first branch? What is the first branch of common hepatic artery? Right gastric artery. Right gastric artery. Then what is the second branch? No, not no. Gastroduodenal. 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 And then it is dividing into two. Then it is dividing into two. One is left, one is right. Right hepatic artery, left hepatic artery. Right? Again, common hepatic artery giving first branch, gastroduodenal artery, right gastric artery, which is giving supply to the laser curvature, and gastroduodenal artery, second, which is giving branch. One is right gastrocolic artery and superior pancreatic duodenal artery. Then the last part, which is called hepatic artery proper, this part giving branch to left hepatic artery and right hepatic artery. Right. So right lobe of the liver obviously will be supplied by right hepatic artery. Yeah. Left lobe supplied by left hepatic artery. Left lobe supplied by left hepatic artery. Now main problem, quadrate lobe and caudate lobe. This is very problematic lobes. Difficult to remember and confusing. Quadrate lobe. See, part of the right lobe anatomically and functionally part of the left. This is very confusing. Quadrate lobe anatomically it belongs to the right lobe. Suppose this is liver. This is quadrate lobe. See this segment. This is quadrate lobe. Okay. This is quadrate lobe. This is right side. This is left side. Because this is the posterior view. This is the posterior view. And this is the anterior view. In the anterior view, we cannot say caudate or quadrate lobe. Quadrate, alphabetically, I remember like this. There are two lobes here. See here. This posterior view. This lower part, this is gallbladder. The part which is along with the gallbladder, this is the quadrate lobe. Size shape also quadrangular. And alphabetically, Q comes later than C. C comes first. So C will be upper. So upper lobe is the caudate lobe. This is doesn't make any sense or any clue. I try to remember like this. C comes alphabetically first, A, B, C, and Q comes last. So Q or quadrate lobe will go down, and caudate lobe comes first. It will remain in the upper part. So this quadrate lobe anatomically it is a part of the right lobe, right and left divided by this inferior vena cava and actually through here like this. Okay, but there is some problem. I don't know why they made this problem, but we have to remember quadrate lobe. Anatomically, it is right lobe, but functionally, it is the left lobe. Just remember this one. Right lobe, and left lobe. Also, we have quadrate lobe and caudate lobe. Total four lobes, four. But mainly we know right lobe and left lobe. But we have two additional lobe. One is quadrate lobe, alphabetically, which comes later and it remains down, means in the inferior aspect, quadrate lobe, and upper aspect, caudate lobe. Inferior aspect, it is related with the gallbladder, and caudate lobe, it is related with the inferior vena cava. Okay, so conjugate segment first. Functionally, they divided the liver in many other segments, segment 1, 2, 3, 4, 5, like this. And no need listing now. Okay, just remember, anatomically it is right lobe, functionally it is left lobe, and porta hepatis lies behind. On the right lies gallbladder fossa. Just we have seen on the right side there will be gallbladder fossa here. In the right side there is gallbladder, and in the left side lies the fossa for the umbilical vein. On the left side, fossa for umbilical vein here. Round ligament. This is the remnant of the umbilical vein here. So one problem solved. Now caudate lobe. Caudate C alphabetically first, so it will remain up. This is caudate lobe. Caudate lobe. Up. Quadrate here. Yeah. Caudate lobe supplied by both right and left hepatic arteries. Right and left hepatic arteries. I think this is the single segment of the liver where it gets supply from both right and left hepatic arteries. Right hepatic artery also gives supply, and left hepatic artery. So it gets supply from both right and left hepatic arteries. Bile from the caudate lobe drain into right and left hepatic duct. Anterior and lateral to the inferior vena cava lies behind the plane of the porta hepatis. Just try to remember the maximum plane. But from this, they make one question and multiple stems they prepare from here. And they will give you confusing stem like caudate lobe functionally represent left lobe. So just read this thing to keep your concept clear. Now see some ligament. This is right lobe and this is left lobe. There will be a ligament called falciparum ligament. Okay, in the anterior superior aspect, which divides the liver into right and left. This is falciparum ligament. Falciparum ligament. Falciparum ligament. Falciparum ligament. Yeah. And inferiorly, there will be round ligament of the liver. Okay, liver. And superiorly, there will be coronary ligament and triangular ligament. Left triangular ligament. Actually, triangular ligament, it is here also you can see. This is coronary ligament. This is coronary ligament, and this is falciparum ligament anteriorly. This is posterior aspect, and this side will go left triangular ligament. Okay, anteriorly falciparum ligament, left side left triangular ligament, and right side mainly coronary ligament, and inferiorly we have round ligament of the liver here, which is just right to quadrate lobe, left to quadrate basically. Now see one point. If a patient is in supine position, there will be some dependent part of the body where most of the fluid accumulates. Okay. It is called hepatorenal recess in between liver and the kidney. The space between liver and kidney. This is called hepatorenal recess. And there will be another one, retrovesical pouch. In female, it is called pouch of Douglas. Yeah, retrovesical pouch. This is pelvic ring. What is this fluid? Okay, this is something putting from the bottle. Maybe lemonade. Okay. Okay. So this is caudate lobe. Caudate lobe. See, caudate lobe. Alphabetically C comes first, N, Q comes later. So it is in the down part. For me, I took long time to absorb this thing. Always I was making mistake. Always. Caudate lobe and quadrate lobe. See, this is a nice picture. Very nice. This is inferior vena cava. Inferior vena cava. Just imagine you are removing inferior vena cava from the liver. So what will happen? There will be a impression. There will be a notch. Remember in our anatomy when we used to study with the viscera. So in the liver, always we had this groove for inferior vena cava. Also here there will be a groove for gallbladder. Here in the down there will be groove for gallbladder. If we hold the liver anatomically and posterior, just anatomically, like in front of us is the anterior surface and posterior to us is the inferior. This is gallbladder. Left to gallbladder will be quadrate lobe, and left to quadrate lobe will be round ligament of the liver, which is the remnant of the umbilical vein. Umbilical vein, normally after birth it disappears, but sometimes it persists as a remnant, which is called round ligament of liver. And ligamentum venosum is the remnant of ductus venosus. These all are important. Just if you remember this information, you will be able to answer. Ligamentum venosum is the remnant of ductus venosus, and round ligament is the remnant of umbilical vein. And remember their anatomical location. This is caudate lobe, quadrate lobe. So now I think you will not make any mistake. Go for inferior vena cava, and this is porta hepatis. What are the structure in the porta hepatis or portal triad? Is it common bile duct? It is not common bile duct. It is bile duct. When it becomes, what is the difference between bile duct and common bile duct? Okay. No, just the reverse. Bile duct forms the common bile duct. This is bile duct, right bile duct, left bile duct. And when it join with cystic duct, then it becomes CBD. Because Dr. Sanjita was working with a legendary surgeon. That's why she knows all of this in our country. Actually, she was studying in our, she's from the same city. Dr. Mamun. Dr. Mamun was her mentor. Okay. Okay. So portal triad, we have hepatic artery, portal vein, and bile duct. Okay. See, they are saying it common hepatic duct. Common hepatic duct also acceptable because it is a right and left hepatic duct. When joining together, it is called common hepatic duct. And when common hepatic duct joining with the cystic duct, which is coming from the gallbladder, then it is becoming common bile duct, CBD. And stone in CBD is a nightmare for any surgeon. Okay. Ligament already we have seen. Calciferum ligament. Just read this part. Artery supply, venous drainage, nervous supply. Okay, okay. Here so it will be more clear. Okay, so see, this is abdominal. This is abdominal aorta giving supply to celiac trunk, and this is our common hepatic artery. Common hepatic artery proper, when dividing terminal branches, they are going to right and left lobe. So one is right left hepatic artery, one is right hepatic artery. Blood vessel already we have seen. Now gallbladder coming. Gallbladder is getting supply by cystic artery during cholecystectomy. This is the common site of bleeding. Okay. Most of the time it becomes very difficult to identify. Most of the time. That's why most of the bleeding occurs from cystic artery. Okay. Mostly cystic artery comes from the right hepatic artery. Mostly. See here, it is coming from right hepatic artery. Yeah, mostly. Sometimes it can even come from common hepatic proper. Okay. Before dividing into right and left, sometimes there may be a branch which gets supplied to the gallbladder. So this is unpredictable. That's why accident happens, because sometimes surgeon thinking in a general cystic artery comes from the right hepatic artery, so they approach in that manner. But sometimes we have to make a window here. Yeah, if there is any anomaly, it will be difficult. So this is cystic duct, common hepatic duct. When joining together, this is CBD, common bile duct, CBD. So again, this is cystic duct. This is okay. This is gallbladder. Okay, gallbladder, 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 gallbladder ending with cystic duct. And from right side we have right hepatic right bile duct. From the left we have left bile duct. Right and left bile duct when coming together and joining with the cystic duct, then their name becoming CBD, common bile duct. Can you repeat again? Yeah. So cystic duct when joined with common hepatic duct, they are becoming bile duct, or formally we say it common bile duct. What is the surgical importance of common bile duct? What we do during cholecystectomy, from which part we remove? During cholecystectomy, do we remove any idea? Very bad, very bad. Patient will die. Patient will make a medical legal case. During cholecystectomy, which part we remove from the body? From where? Gallbladder. But up to where we make a cut? Yeah. Where we put the clip? Okay. One is artery. This is cystic artery. Okay. Cystic artery done. Then another one. Patient will make medical legal case even before you go to home. And patient, no. Be very clear. It is very simple. See, patient, our stone is in gallbladder. Okay, and this is causing the problem. And there is SARS, there is inflammation. It became inflamed, cholecystitis. It became inflamed because of the cholelithiasis. Okay, or maybe there is some pus inside. Okay, so we need to remove this inflamed part. What we will do first? We will stop its main energy supply, which is the arterial supply, cystic artery. Our first priority is to find out this triangle. Because cystic artery mainly will remain in this triangle. This is surgeon's main approach, which takes time. Remaining excision is very easy. Main challenge is to find out this triangle. Then they clip the cystic artery to stop bleeding. Then they just try to make sure that this is cystic duct. And how they make sure? Because it is joining with, even by mistake also they cannot put any clip on the common bile duct or in the uh, common hepatic duct. Okay, they should not, because if they clip hepatic duct, bile cannot come. Bile cannot come, and you are ultimately occluding circulation. We must keep the passage free for the bile. So bile how will come? From the right side, from the left side, they will come to the common hepatic duct. And if this passage is clear, then they can directly meet into the second part of the duodenum. There is no problem. So surgeon, what they do, they make a clip in the cystic artery and they make another clip on the cystic duct. And then they cut, stitch and close. OT not discharge. Finish. But by mistake, if there is any injury, because sometimes during surgery, the stone may dislodge from here and it may go into common bile duct. It may go into common bile duct. In that case, we require another procedure which is called ERCP. T-tube, we put T-tube and we do, yeah, of course we put T-tube and to remove that stone, if stone in CBD, then we use ERCP. Endovascular retroscopy cholangiopancreatography. You will read this thing in MRCS, then it will be easy. Okay, so nerve supply, sympathetic, okay, cystic artery, branch of the right hepatic artery. Okay, nerve supply, sympathetic, mid-thoracic spinal cord and parasympathetic anterior radial trunk. Common bile duct. Common bile duct. Just read it. Hepatobiliary triangle. Important. Hepatobiliary triangle. Hepatobiliary triangle. This is hepatobiliary triangle. Hepatobiliary triangles. Superiorly, what we have superiorly? Suppose this is hepatobiliary triangle. This area. Superiorly, we have inferior surface of the liver. Okay. Inferior edge of the liver. Then inferiorly what we have? Inferiorly, this is superiorly. Inferiorly, we have cystic duct. And this is medial side, because the lateral side of the body, this is medial side. And medially, we have common hepatic duct. Why it is important? Because the blood supply to the gallbladder comes from here. So it contains cystic artery. Cystic artery is very important. Cystic artery is the branch of. Very good. Now pancreas. Pancreas is a retroperitoneal organ and lies posterior to the stone. The tail lies close to the hilum of the spleen. Okay, so this is pancreas. For pancreas. So it has head, neck, body and tail. Head remains within the curvature of the duodenum. Right? Here will be the uncinate process. Then neck. Behind the neck there will be major structures or the main blood vessel. Then body and the tail. Tail is attached with the spleen. You have to read the relationship. Posterior to the pancreas. Behind the head, inferior vena cava. Just from the picture you can see head. This is head. So behind head, what are the structure? Inferior vena cava, common bile duct, right and left renal vein, because vein remains in which side of the body, right or left? Vein remains in the right side and abdominal aorta remains in the middle. We said yesterday that abdominal aorta remains just over the spine and spine is the middle, right? And inferior yeah, left to superior vena cava. Yeah, left to superior vena cava. Behind the head we have inferior vena cava, common bile duct, right and left both. Right renal also coming here and left also going this side. So both just behind the head. Which one is longer? Renal vein, right or left? Left renal vein. What are the other vein draining left renal vein? Very good. Left suprarenal and left gonadal drain into left renal vein, and left renal vein drain into inferior vena cava. And right gonadal, inferior vena. Okay. So superior mesenteric artery and superior mesenteric vein, both superior mesenteric artery, superior mesenteric vein, both remain behind the neck. This was my MRCS part B exam question. Then neck. We are saying posterior to pancreas. These all structures are behind pancreas. Behind head we got some structure. Now head finish. Now come to the neck. So behind head we got big structure. Inferior vena cava, superior mesenteric artery, superior mesenteric vein, and some other like meeting finish. Yeah. Actually, yeah, sometimes 60, sometimes they give. If it is only two members, then it is infinitive. But if it is more than two, it is restricted to sometimes 90 minutes, sometimes 60 minutes. Okay, you can see the screen. Okay. Okay. So behind the neck, we have superior mesenteric vein, portal vein. You have to read it many times because it is confusing. Behind the head, we have superior mesenteric vein. Behind the neck also we have superior mesenteric vein. Okay. They may ask which of the structure is behind both head and neck of pancreas. Superior mesenteric vein, okay, and portal vein, because superior mesenteric vein along with splenic vein, they are forming portal vein. So exactly this part is behind the head and the neck. This part, especially here. Okay. Then body. Body is simple. Left renal vein, cross of the diaphragm, especially the left psoas muscle, left adrenal gland, left kidney, and the aorta, abdominal aorta. Okay. And the tail behind the tail will be the kidney. So yeah, left kidney only, left kidney. Right kidney will not come in any relation with pancreas. Now anterior to pancreas, head, first part of the duodenum, pylorus of the stomach, gastroduodenal artery, superior mesenteric artery. See, posterior to the pancreas, we have superior mesenteric artery, SMA. And anterior to the pancreas, also we have SMA and SMA, both. Very confusing, right? Anterior also some structure, same structure, even posterior also. And it is mainly in the uncinate process. Uncinate process here. This part actually we cannot see. See this structure. It is something, see this picture properly. These are the structure. This is superior mesenteric vein and this is superior mesenteric artery. Now pancreas, here is the pancreas, but after this also still there is pancreas up to here, like this, but it is covered by these two structure. So in this case, superior mesenteric vein and superior mesenteric artery is anterior to pancreas, head of the pancreas. But if you go here, just above, little above pancreas, this is pancreas, and here you can say this is neck, and here also. So here it is covered by the pancreas in this part, and it is coming in this manner. So ultimately this part of the superior mesenteric vein and superior mesenteric artery is covered by actually head. Neck will start from here, then body and tail. Okay. Head, first part of the duodenum, pylorus of the stomach, gastroduodenal artery. Which artery bleeds in peptic ulcer disease? Gastroduodenal artery. Yeah. And the body. Anterior to the body will be the stomach and duodenal flexor. Remember, in transpyloric vein, what are the flexor we got in transpyloric vein? Hepatic flexor, splenic flexor. Okay. And tail with splenic hilum. Then artery supply. This is exam question. Artery supply, head. This is head. Then neck, body, and tail. Okay. So head part is getting supplied. We have seen pancreaticoduodenal artery, which is a branch of and rest part is by splenic artery. So it is very easy, artery supply, right? Only head part is supplied by who? Pancreaticoduodenal artery. And remaining part is by Splenic artery. Splenic artery is the branch of very well. Celiac trunk. So head of the pancreas is supplied by pancreaticoduodenal artery, and rest of the pancreas is supplied by pancreatic branch of the splenic artery. Better to say like this, pancreatic branch of the splenic artery. Because the splenic artery, when we have seen before, we have seen three branch. One branch is short gastric giving supply to the fundus. Then we have left gastroepiploic giving greater curvature, and another branch is pancreatic branch, right? Okay. Now venous drainage, same head part drain into superior mesenteric vein, just corresponding vessel, pancreatic artery, and here head part superior mesenteric vein, and body and tail to splenic vein. Okay. Ampulla of Vater, marge of the pancreatic duct and common bile duct, between regions supplied by the celiac trunk and SMA. Ampulla of Vater or opening of the mesoduodenal papilla, same thing. And it is an important landmark because up to there, second part of the duodenum, anatomically from foregut to mid bursa. We have seen this one before. Okay. Now again have a look. This is a very clear picture. Pancreas, spleen, head of the head and uncinate process. Head, uncinate process is something I remember it like the unseen process. Uncinate is unseen process of pancreas. Why it is unseen? Because it is covered by superior mesenteric vein and superior mesenteric artery, which is anterior to uncinate process. And this part is supplied by which artery? But more specifically, uncinate process. I forgot. I studied it in second part maybe. Uncinate process with superior pancreaticoduodenal artery. I will make sure. Blood supply, okay. Blood supply, three sources. Superior pancreaticoduodenal artery, okay. Superior pancreaticoduodenal artery, it is from gastroduodenal artery, right? Inferior pancreaticoduodenal artery from superior mesenteric artery, and pancreatic branches from the splenic artery. See, now you will be more clear. Celiac trunk, we have right gastric artery, first branch. Then second branch, we have gastroduodenal artery. Gastroduodenal artery again dividing into, one is superior pancreaticoduodenal artery, right? It also has anterior and posterior. One branch coming anteriorly, like this one. So this is anterior superior pancreaticoduodenal artery. Anterior superior pancreaticoduodenal artery. This branch coming anteriorly. Another branch going posteriorly. So this is posterior superior pancreaticoduodenal artery. and from anterior superior pancreaticoduodenal artery. We said that gastroduodenal artery giving two branches. One is right gastrocapillary artery. Remember, we said during stomach blood supply, gastroduodenal artery giving two branches. One is superior pancreaticoduodenal artery, another one is right gastrocapillary artery, giving supply to the greater curvature in the lower part. Basically, this part, more specifically, if we want to say, this is coming from anterior superior pancreaticoduodenal artery. If the exam question becomes very difficult, they will be more specific like this. Mhm. Yes, yes, yes. Yeah. Before we said as a gross, but now it is more specific. It has superior, before we said superior pancreaticoduodenal artery and inferior pancreaticoduodenal artery. But now superior also has one branch anterior, one branch posterior. Posterior remains as posterior, no doubt. And this posterior but superior pancreaticoduodenal artery coming down to join with posterior inferior pancreaticoduodenal artery. Okay, I think clear. Then superior anterior pancreaticoduodenal artery coming down to meet with inferior anterior pancreaticoduodenal artery. These both inferior branches of the pancreaticoduodenal artery are the branch of superior mesenteric artery. So superior mesenteric artery giving branch, one branch anterior, one branch posterior. That's why their name is anterior, but according to location, this is inferior and this is superior. That's why their name are the superior. Superior but anterior, superior but posterior. And these branches inferior but anterior, inferior but posterior. Okay. So inferior joining with superior and anterior joining with anterior, posterior joining with posterior. Specifically, right gastroomental artery or gastrocapillary artery coming from anterior superior pancreaticoduodenal artery. Okay. Vessel encounter during Whipple surgery. Vessel encounter during Whipple surgery. This is also part B. These all are part B exam question. Abdominal aorta. Do you have idea about the Whipple's procedure? Whipple's procedure. Um, Whipple's procedure. Yeah, this is a yeah during pancreatic. Mm-hmm. Yes. Okay. See, this is Whipple procedure. Whipple's procedure. Here, before the procedure, what structure we had as like normal anatomy. Okay. Vessels encountered during Whipple surgery: abdominal aorta, superior mesenteric artery, superior mesenteric vein, portal vein, left renal vein, splenic vein, superior and inferior pancreaticoduodenal arteries. So this is pancreatic tumor in the head of the pancreas. So they remove head of the pancreas, they remove uh, duodenum, pylorus of the stomach, gallbladder, sometimes bile duct, duodenum, jejunum, part of the jejunum, and then they make pancreas directly attaching with the jejunum and bile duct, hepatic duct actually, not bile duct, hepatic duct. Hepatic duct, they are anastomosing with intestine and stomach. This part they are making stitch. Here there will be stitch. Then how the content will go? Directly there will be another tunnel opening with the inferior in the greater curvature. They connect it with the intestine. So directly food coming from here and it is going to the intestine, and bile coming from the liver and it is entering into the intestine, and pancreas also giving its supply, pancreatic juice. So pancreaticoduodenojejunostome. Pancreaticoduodenojejunostome. Okay. Ligament encounter. Just yeah. This is all single question. Peritoneal relation of the pancreas. All is retroperitoneal except for the tail. Only tail of the pancreas is intraperitoneal, and all other part is extraperitoneal or retroperitoneal or out of the peritoneum. Vessel present body of the pancreas, behind body of the pancreas, head, neck, body, and tail. Behind body of the pancreas is splenic artery, right? Vessel present behind the neck, portal vein. Space present in front of the pancreas, laser sac. This is greater sac and this is laser sac. In between greater and laser sac, there is a communication that is called epiplexora. Okay. Development of the pancreas, ventral part, dorsal part. Spleen, just some gross information. Embryology, they derived from the mesenchymal tissue and their weight is 75 to 150 gram and their position between 9 to 12 rib. Their content, they have white pulp and red pulp. Red pulp filters abnormal red blood cells, and white pulp, they have immune functions. It was in my exam in part A. Okay. Already we have seen this part. Splenic vessels are enclosed inside the linorenal ligament. Okay. Left gastrocolic and short gastric vessels are enclosed in the gastrosplenic ligament. splenic vessels are enclosed inside the linorenal ligament because spleen, head of the tail of the spleen. This is head, neck, body, and tail. Tail of the spleen when joining, they are joining with the hilum of the kidney. Sorry, hilum of the spleen. Hilum of the spleen. And just behind it will be the kidney, right? There. So linorenal ligament. This vessel, here this vessel will be enclosed with linorenal ligament. And left gastrocnemic, here is the left gastrocnemic, which comes from the splenic. Remember, splenic artery give left gastrocnemic and left gastroduodenal. Sorry, short gastric, short gastric vessel and left gastrocnemic vessel. They are enclosed in gastrosplenic ligament. Here will be the greater curvature of the stomach and the spleen. So these vessels will remain into gastrosplenic ligament. Now esophagus, very easy. It begins at the lower border of the cricoid cartilage and vertebral level cervical 6. Okay. Esophagus begins at cervical 6 vertebra or cricoid cartilage. Esophagus we can divide into 3 parts: upper third, middle third, and lower third. Upper third artery supplied by inferior thyroid artery. Okay. Vein, inferior thyroid vein. Middle third, just remember the esophagus. It is starting from C6 and ending at which level? Esophagus ending at which level? T2. Very right. So, is there anything remaining to say T8, T12? Then only T10 remaining. Unfortunately, that is the correct answer. Yeah. Yes. This is 8. This is T8 for vena cava. Then T10 for esophagus. Esophagus with which nerve? Esophagus vagus. Esophagus vagus. Yeah, esophagus vagus. And T12 is for Sanjida. What is the content of abdominal aortic opening? Yeah. So it is divided into upper 1/3, middle 1/3, and lower 1/3. Upper 1/3, it is getting supply from here will be the thyroid, right? Thyroid. Thyroid, here will be the thyroid. So it is getting supply from inferior thyroid artery, venous drainage to inferior thyroid vein. Then the middle 1/3, due to their anatomical location, it is very closely attached with the aorta. So it will get supply from the branches of the aorta. That's why middle third from the aortic branches and vein will be the azygous vein. Vein will be the azygous vein. And lower 1/3, we have seen that here will be this is funding part, and this is laser curvature of the stomach, right? And just we have seen from here celiac trunk arising, and we have a blood vessel giving supply to the laser curvature. What was the name of that vessel? Left gastric artery. Sorry, left gastric artery. One branch giving up, one branch again descending with the laser curvature. So this ascending branch actually giving supply to the lower part of the esophagus. And basically, this is a branch of left gastric. So lower one third from left gastric, upper one third from inferior thyroid, and middle one third from the branches of the aorta. Now venous drainage, upper third by inferior drain into inferior thyroid vein, middle third to esophagus vein, and lower third to left gastric vein. Lymphatics, upper third to deep cervical lymph node, middle third to mediastinal, and lower third to gastric. Now muscle, upper third it is striated muscle, and lower third, as lower part is joining with the stomach, and stomach it is a smooth muscle. So smooth muscle, so lower third also it will be a smooth muscle. Upper third is striated muscle, lower third is smooth muscle, and middle third is the mix of both smooth muscle and striated muscle. Okay. Now आज के लिए छुट्टी खलास we will finish. We will finish here. So we reached up to 60. Just this part we will finish. Lining of the esophagus is striated squamous epithelium. Stratified squamous epithelium. Stratified squamous epithelium. Okay. And what is Barrett esophagus? Columnar metaplasia with increased risk of developing adenocarcinoma. What is Barrett esophagus? Actually, in the lower part of the esophagus, there is a sphincter, esophageal sphincter, right? We know this one, which controls. This is lower part of the esophagus. We have a sphincter here, and from here will be the stomach. Okay. What it causes? It has only one way direction. It allows food only to pass from above downwards, but it never allows food to pass from stomach to esophagus, right? Normally, in abnormal condition, for example, vomiting. When we vomit, sometimes content from the stomach, even from the bile, even from the intestine also, they can come through the stomach, through the esophagus, and out of the mouth, which is we call vomiting. But this is not normal. Normally, when we swallow, there will be peristaltic movement in the esophagus, and it causes forward movement of the food body. So it passes. And this lower esophageal sphincter, in this area, stomach epithelium is columnar epithelium. Inside the stomach, the epithelium are columnar. But the esophagus, these are stratified squamous epithelium. Stratified squamous epithelium, and here we have columnar epithelium. So there is a junction where, in this junction, columnar epithelium and squamous epithelium. We have idea about squamous, right? Squamous is like the flat epithelium, and columnar will be like this, like column shape. Why this column shape? Because they need to contain a lot of gland for the secretion of the gastric juice. Okay, and this is squamous epithelium. Why? They just form a outer layer or the covering. Okay, if there is excessive acid reflux, then there is some change. Metaplasia means one type of cell convert into another type by some influence. Here the influence is acid, gastric acid. Because of this influence, there will be some change. So columnar metaplasia occurs here. Okay, and that's why this adenocarcinoma is the carcinoma of the columnar epithelium. Okay, adenocarcinoma, mainly the cancer of columnar epithelium, which occurs into the gut because of their epithelial lining. And squamous cell, they have the carcinoma. like squamous cell carcinoma, right? So due to the excessive acid reflux, there will be columnar metaplasia, which increase the risk of adenocarcinoma. This is Barrett esophagus. Exam question, they ask in Barrett esophagus, which type of metaplasia occurs? This is columnar metaplasia. And what is achalasia? Just the same topic we discussed, that esophageal achalasia is the esophageal motility disorder involving the smooth muscle layer of the esophagus and the lower esophageal sphincter. Okay, and it is characterized by incomplete lower esophageal sphincter relaxation. Normally, when we swallow any food, we both are not sleeping, right? You are very silent. Okay. Lower esophageal sphincter relaxes. When we swallow any food, lower esophageal sphincter relaxes and it allows the passage of the food. But if there is any incomplete relaxation, some food particle stuck there and patient feel very difficulty in swallowing. So increase lower esophageal sphincter tone and the lack of peristalsis of the esophagus. This is called achalasia, achalasia cardia. A microscopic picture of the achalasia. It is a disorder and because of the absence of the minatory plexus. Lymphatic drainage, we have seen. Complications of the perforated esophagus, it causes medistenitis. Now, constriction of the esophagus. We have in 4 level. Esophagus has constriction in 4 level. This is the distance from the incisor tooth. Incisor tooth. After 15 centimeter, there is a constriction which is caused by the cervical at the region, and it is caused by cricopharyngeus. Cricopharyngeus. At 22.5 centimeter, because of the arch of the aorta, there is aortic constriction. At 27.5 centimeter, by left main bronchus, they have a constriction called bronchial, and after 40 centimeter, because of the diaphragm opening, they have diaphragmatic constriction. So first we have junction of the esophagus with the pharynx. Pharynx and esophagus, when they are joining, because of the cricopharyngeus, there is a constriction. Cricopharyngeus, and it is just 15 centimeter from the incisor tip. Then at 22 centimeter, they have constriction because of the bronchi, arch of the aorta. Arch of the aorta, 22.5. Then just 5 centimeter below, there is bronchus. From here, only 5 centimeter. So it will be 27.5 by left main bronchus. And then when it is entering into the diaphragm, because of the diaphragm, there will be constriction and it is almost 40 centimeter from the incisor tip. And now the parts of the stomach, fundus body and pylorus. Blood supply already we have seen in details, right? Blood supply of the stomach. No need to repeat again. So we finished up to page number 61. Only 10 pages remaining. We will finish it tomorrow. So we'll start from the duodenum. We almost covered the most of the important part. Very few things are remaining. Okay, almost done. So we will conclude here tonight. And Sonia, you are there? Okay, so now I will. Now I will send you the mock question. Both of you be honest. Okay, give exam honestly. No need to give it now. If you can give it now, it will be okay. But you can do it later also. But send me the answer as like you did today. Yeah, you can finish before. Yeah. For me also here it is night. I'm also in this hut. Finish before. Yeah, yeah. And tomorrow we will finish abdomen, then we will have our whole abdomen mock, and then we'll proceed to the next. Okay, okay, then we will conclude our session here today, and thank you for joining. Yeah. It was a very boring lecture by a very boring teacher. So just you are now relieved.